Hi, everybody. I'm François. I'm a physician based in Joburg. I've been involved in PrEP programs for the last couple of years, and I'm here to talk to you about successful models of PrEP implementation. These are my disclosures. So I just want to do a quick shout out to two groups of people who I think don't get enough attention for the amazing work they've done over the last decade on PrEP. Both AVAC and WHO PrEP people, they've really kept it front and center, the advocacy and the implementation agenda. So I haven't seen the previous studies and talks that have come with this symposium, but I'm sure this has been up there. We've got these amazing interventions, which are as close as damn it to getting us to 100% protection. And with the onset of long-acting injectables and orals, we are going to get to 100%, I have no doubt. So we have this phenomenal biological preventive that is available, that is cheap and cheerful and very, very safe. The problem is it's just not being used. And it's not just being used, it's not being used in every single corner of the globe. And when you look at this graph, it tells you everything you need to know. I downloaded it last night from PrEP Watch, which AVAC maintains. It's an amazing website, which has all these resources on it. And you can see places where the epidemic is raging in Southern Africa, in Eastern Europe, all over the globe. The numbers of new PrEP initiations is practically homeopathic. And so in summary here, we have this remarkable intervention that is safe, highly acceptable to patients, that policymakers and governments and donors have embraced, and yet no one is using. And it is just one of the tragedies of modern HIV, of the modern HIV era, that PrEP is out there and yet is not being taken up. And as opposed to treatment, where we are as close as sued, there are obviously holes in the program, but we really have been successful in terms of access to ART. So I was tasked to go and find successful models of PrEP implementation, and it was actually really, really hard. There are very few, and they are largely focused on cities, I'm afraid. There are counties in the United States, there are countries in Europe that have managed to contain their HIV epidemic, partly using PrEP, largely because they've integrated PrEP in hotspots within their city. So you'll look at places like San Francisco, New York, Melbourne, London, cities in Europe, and you'll find that the countries, the counties in the US have managed to contain their HIV epidemics using PrEP as part of the package of care and done remarkable jobs in terms of their containment. Outside of there, though, PrEP has largely been successful in verticalized programs. In my own, in sex worker programs I ran, where it was used in Men Who Have Sex with Men, intravenous drug user programs in trans populations more recently, all programs where they provide a verticalized service, that provide HIV testing, reproductive care, ARVs. It's very easy to add PrEP to a verticalized program. But I could not find any large-scale successful program amongst young women. You can find, pilot projects, you can find programs where people have done well with very, very focused resources, but no large-scale programs which have been successful to the group who most need them. And Mitchell Warren gave this impassioned plea at one of the WHO meetings a couple of weeks ago, which I found absolutely amazing. We just pointed out and just said, PrEP is a failure. When you look at implementation, it is an absolute failure. Outside of, as I said, these cities and these verticalized programs, we have not made the inroads that we need. So I'm going to use South Africa as an example, not because I'm focusing on the people who failed to provide. People work really hard in PrEP in South Africa, but because it is, I just know the program so well, and because it does signify a problem that is seen across the globe. And you can see how that South Africa has started less than 200,000 people on PrEP over the last few years and has a target of reaching 250,000 in the COP 2021. And as I said, I'm using South Africa because that's pretty much the experience everywhere else. But South Africa is a very large country. It's the largest country in the region. It's a rich country relative to the others with lots of money invested in its healthcare system. It has anything between 10 and 30 million people eligible for PrEP. It's had 6 years of PrEP as public policy with lots of enabling guidelines for both the public and the private sector. But all the PrEP has almost pretty much been in verticalized programs. More recently, there have been some inroads amongst young women, although again, these have been pretty, as what I would certainly call verticalized programs. We have made some inroads, but when you look at the number of young women who've been eligible for PrEP, it's very, very small. But look at the private sector, only 2,000 people ever initiated on PrEP over the last few years. It really is remarkable how badly we've done when you look at how well we've done with the ART program with HIV positive people. And we have a raging epidemic amongst young women. We have a pretty bad epidemic amongst MSM. We have a severe epidemic amongst sex workers and amongst IDUs. PrEP should be part and parcel of our HIV program, but it has not reached the numbers that we need. And here again, you can see the numbers. The numbers are increasing amongst all these groups here in South Africa, but very slowly. And it really is testament to a program that is not being aggressively increased at the numbers that we need to get to epidemic control. So we need to talk frankly about why we've done so badly. And I think it is more complicated than sometimes if people just say, oh, it's a lack of political will, it's a lack of resources. I don't think it's always that. I think sometimes we've misportrayed PrEP. I think the first thing is we've often treated PrEP as ART provision, and that's nonsense. It's really much more like contraception. And often you see people talk about, loss to follow-up. When people have simply, their period of sexual risk is gone, they've stopped taking PrEP, and that's completely reasonable. They're not lost to follow-up. They just don't need the treatments, or they don't need the preventive. And I think we need, again, to acknowledge the fact that this was a major misstep on the policymakers to start using this language. I think the other problem is that PrEP proponents have often said it's very easy to provide the service, and it really is not easy. It's very easy in a verticalized program, but in normal clinical care, it's actually very hard. Where you've got long queues in front of you, identifying people at risk, having long conversations about it, providing in the context of broader reproductive care is actually really difficult in underserviced primary healthcare services. It's also, for young women, had really been put into primary care at the site of often very unfriendly staff and very judgy staff as well. And and it's no surprise to me that the numbers of young women taking up the services in these situations is actually very, very low. They also, for programs themselves, we've managed as program designers, managed to put up umpteen obstacles, everything from renal monitoring to HIV testing in window periods, raising concerns about whether self-testing is good enough, managing to make difficult lead-in periods by making it different for men and women. All of this, it's just added lots and lots of program complexity. It's been interesting to think about whether these new drugs are going to save us, and it certainly is remarkable the amount of money and the amount of effort and just the amount of creativity that's gone into all these new products that are coming at us thick and fast. And particularly these long actings, both the orals and the injectables, I just think are incredibly, incredibly exciting. But will it save us, and will it save these programs? And I think the important thing is that firstly, we should have probably invested a lot more in the implementation side of PrEP. It's easy to have 2020 vision retrospectively, but this is something we need to be thinking about, and thinking about putting far more investments in trying to, if we are going to invest in these long actings, to make sure that the implementation follows at the same time. I don't think by themselves they're going to overcome bad systems, but maybe it's the kick in the pants, these particularly injectables, but also long actings, orals, that we need to start thinking much more creatively about providing the systems of care that are going to be required to get the PrEP numbers that we deserve. WHO, I think, is getting a bit fed up at the moment, and is trying to look at making guidelines thicker and faster, and just making it just removing some of the obstacles that we're seeing within conventional guidelines. I think I'm seeing the rise of people being more bullish about resistance, not being as fearful about it that we saw in the first few years, saying let's get stuck in and get PrEP out there and just monitor, and we'll pick up the pieces if resistance truly does occur. I think we're making our peace with the fact that the renal, particularly tenofovir and TAF, are very, very safe in terms of the renal side of things. So finally, just some final thoughts about PrEP. And I do not think that we are going to get the numbers that we need unless we have a radical rethink on how we offer PrEP. And I think these new long-acting agents are a major opportunity to start thinking about how we're doing that. I think we obviously need to weigh the ease of access versus the trappings of the program, the creates and the multiple HIV testing and the fear of resistance. And as I said, I think some of that is falling away now. And we need to be thinking is how do we get the drugs to people and stop making the program itself an obstacle to getting access to this. These drugs are very, very safe. We now have decades of experience with tenofovir. We got more and more experience with TAF. We're rapidly going to have experience with these long actings. The resistant issue is slowly falling away. We need to make our peace with the fact that we don't need to be overconfident, overconscious of the safety issue. And I think we need to be talking so hard with our colleagues from the contraceptive field to start thinking about how we deal with contraception. How do we take those lessons from the contraceptive field and make PrEP available broadly in the same way? And finally, we need to be radical about, and this is obviously going to vary from country to country and from context to context, but start thinking about much easier ways to access PrEP that isn't outside of primary healthcare, outside of the GPs, outside of however we're doing it at the moment is just far from good enough. We have to step beyond our normal boundaries and start getting PrEP to the people that need it in a way that suits them and does not suit just the healthcare system. Thank you very much.